Okay, oxygenation. All right, this is the process of loading the oxygen molecules onto the hemoglobin molecules in the bloodstream. So your red blood cells have these little protein structures known as hemoglobin. That is what actually carries the oxygen um, on the red blood cell all the way down to the big toe. Okay, this is a requirement of this in order for this to happen is what's known as internal respiration. Okay, internal respiration is basically another way of saying gas exchange at the alveoli level. Again, just another term that you guys might see. It is basically respiration. We just call it internal respiration. Okay, this does not guarantee. Okay, just because we breathe in oxygen does not guarantee that internal respiration can occur. If we have injury to our lungs, if we're fighting some kind of infection, if our lungs are what's called hyperinflated due to some disease processes where we can't get that snap back of our lungs, it's kind of like if you guys take a rubber band. Okay, this is the best example of it. And you're going to hear this again also when I talk about the heart. It's kind of like if we take a rubber band and we have this brand spanking new rubber band and we hold it between our thumbs and we keep stretching it and releasing it, stretching it, releasing it, stretching it, releasing it, stretching it, releasing it over and over and over again. Eventually, that rubber band is not going to have the snap that it used to. Okay, there's some disease processes such as smoking or toxic inhalation that's actually destroying the stretch of our lungs. And if we destroy the stretch of our lungs and they're already hyperinflated when we take that breath in, we're not creating that pressure gradient in order to help with the diffusion process of oxygen and carbon dioxide. Okay. Also, ventilation with oxygenation can occur where oxygen levels have been depleted. Okay, such as if we're down in mines, right? If we're really far under the ground and the air is extremely thin down there, we could still be breathing normally, but it doesn't mean that the oxygen that's contained in the air is necessarily being involved in internal respiration. Okay, this can also happen in confined spaces, specifically with you guys going into the fire department. This is happening anytime that something is on fire, right? That's why you guys are going to be trained to use the self-contained breathing apparatuses in order to help with that pressure gradient when you guys are inside fighting a fire. Okay, respiration. This is the actual exchange of oxygen and carbon dioxide at the alveoli level in the body, also known as gas exchange, right? This is where life occurs, guys, okay? If we can't get that good, adequate gas exchange, we're going to start having cells die on us, and we're going to start entering the early stages of shock. And remember, we talked about this a little bit already. There's two enemies that we have in EMS. The first one is shock, which we can actually do quite a bit for, and the next one is ICP, or intracranial pressure. We're going to talk about that more when we get into trauma. All right, but once we get that oxygen into our cells to produce energy, the cells take that energy from the nutrients through metabolism, and they help us eliminate waste and do our normal everyday body functions, whether it's if we're running and working out, or perfusing our organs, or if we're about ready to eat, whatever we're doing, oxygen is the key for all the energy that takes place in our body. External respiration, also known as pulmonary respiration. So we've already talked about internal, which is that ability to get the air in and out of our lungs in order to get the gas exchange at the alveoli level. This is where we're actually bringing that fresh air into our respiratory system. Once we get the air into our respiratory system, the gases mingle, and then we blow out the nastiness in order to help with the actual perfusion of gases in our pulmonary capillaries in order to be able to use them for energy. The internal respiration is the exchange of oxygen and carbon dioxide between the systemic circulatory system and the cell. So the internal respiration truly takes place all the way down at like your big toe when we have a good pressure gradient, because we have good pressures in our system, such as like a good blood pressure. We have a good functioning heart to help circulate that oxygen molecules all the way down there. And this is the onloading of oxygen into the cells, and the CO2 is released from the cells in order for us to breathe it out. Timing is crucial And remember, we're going to talk about this a little bit more in respiratory emergencies. But usually when we're dealing with a respiratory emergency, specifically in the pre-hospital setting as EMS providers, we are responding to the patients that have already that have been diagnosed with a respiratory issue, possibly in the past. They know they have this. They have many tools at their own home to fight this, such as medications or possibly oxygen administration devices that they can use. And they have already tried all measures that they could do at their house, and now they're calling us, right? So usually when we are responding to a 911 call, when somebody does call 911, we are already behind the 8 ball, and we have to be pretty aggressive when it comes to actually making sure that we are getting good oxygenation to our patients and making sure that oxygen is being used as adequate gas exchange, known as respiration. Okay. After a minute, you guys can see that's not a long time, guys. After a minute, we start pissing off the heart. Okay. For about 0 to 4 minutes, we're going to start kind of thinking about, hey, the brain's going to start getting irritated now. We could start seeing some crazy stuff going on with our patients, such as they might be becoming irritable. They could become combative on you. They can have some kind of altermentation. They might be becoming confused. All right. Once we get up to 6 minutes, we're starting to kill off the brain. Okay, we're starting to kill off the cells of the brain. And then anywhere after 10 minutes, more than likely we are going to be the patient's going to be suffering some kind of brain damage, some kind of secondary brain injury, okay, because the brain has been without oxygen for that long. Once after we get past that 10 minutes, we are looking at irreversible brain damage, and more than likely the patients are going to have severe deficits from not perfusing their brain and not giving the brain the oxygen that it needs. Okay, jumping ahead again, when we're talking about pathophys of the respiration, remember that chemoreceptors in our brain monitors level of oxygen and carbon dioxide and hydrogen ions in order to maintain our pH in our body. We talk about the ventilation/perfusion ratio, what we also call VQ mismatch. You guys will get more of this when you get into paramedic and whatnot. But Bailey, this is a failure. This is a failure caused most by the abnormalities of oxygen and carbon dioxide exchange, whether it's some kind of factor such as some kind of infection or something like that, right? So when we're talking about factors that will actually affect the pulmonary ventilation, we need to make sure that we are maintaining the patient's airway for them, specifically if they're unresponsive. And I'm going to say this once real quick for you guys, okay? Just so you guys know, the only way to guarantee a true patent airway in your patient is if they are able to swallow, okay? If your patient is able to swallow, they are able to protect their own airway. If they are not able to swallow, for whatever reason, maybe they're unconscious, maybe they've had some kind of traumatic event happen to them, maybe they have some disease process that's prevented them from actually swallowing, they do not have a patent airway, okay? If the patient's not able to swallow, their chance of vomiting goes up like 100 times, guys, okay? And we need to make sure that we're able to protect that airway for them. We're going to talk about things that we can use later on in this lecture on how to help our patients out with that. However, some intrinsic factors that will actually affect pulmonary ventilation are your infections, like in a pneumonia, okay? Allergic reactions, okay? It could be asthmatics, right? Their actual airway is swelling shut. They're not able to get all that carbon dioxide out or enough oxygen in. Or if they are completely unresponsive. And remember that the tongue is the number one occluder of the airways. Extrinsic factors would be any kind of trauma that has damaged the airway, whether it's the upper airway, the lower airway, wherever it is. Trauma has a big intrinsic factor for pulmonary ventilation. And anytime we have a foreign body airway obstruction, and remember, foreign body airway obstructions are definitely more prevalent in our children, specifically our neonates or our babies, our very young people, because they explore the world by putting things in their mouth, right? So foreign body airway obstructions are very prevalent in our younger population. Okay, some factors that can actually affect respiration. All right, some factors that can actually mess with the adequate gas exchange at the alveoli level. It could be atmospheric pressure. Okay, if you guys decide to climb Mount Everest one day or something like that, or try to climb the Himalayas or something like that, the air is getting thinner, right? So we're not actually able to get good, adequate respiration because we're not technically getting enough oxygen into our body in the first place. And that also goes with the partial pressure of oxygen, right? It's easier to breathe at sea level than it is to breathe where we are in Albuquerque, just over a mile up, all right? Internal factors, same thing as almost as ventilation, right? If we have a pneumonia, if we have all this pus kind of sitting in our lungs, or any kind of fluid, whether it be pus or blood or just regular plasma or whatnot, this is going to affect our internal factors for respiration. Pulmonary edema is just a sexy term for fluid in the lungs. It could be plasma from our blood. It could be blood itself. It could be water from a near drowning. And it could be pus as far as the pneumonia, okay? And then any kind of COPD or emphysema. We'll talk about those when we get into respiratory emergencies. But those are long-term exposure to some sort of toxin. Remember, it doesn't have to be just smoking or secondhand smoke, right? These could be people that are working with chemicals that just happen to be breathing these in. Welders, actually, if they're not ventilating correctly, welders can get some really nasty stuff breathing in from the actual fumes of the actual metals that they're melting as well. Compromises to the circulatory system, okay? Trauma emergencies typically obstruct blood flow to individual cells and tissue, right? If we develop a bruise somewhere, we're technically not perfusing that area because we have damaged the capillaries around that area, right? We're going to talk about pulmonary embolisms. A pulmonary embolism is basically a blood clot in the lung. We're going to talk about that more in respiratory emergencies. Simple or tension pneumothorax. This is where you actually have a hole in your lung, and we're going to talk about that more when we get into trauma. An open pneumothorax is basically we have a hole from something outside in, so some kind of penetrating trauma has actually decreased the pressure gradient. We're going to teach you guys how to treat that at the basic level. Hemothorax. Hemo, anytime you see hemo, it means blood. This is where we actually have blood in our chest cavity that could be pushing on our lungs in order for our lungs to not be able to expand correctly. And hemopneumothorax is where we have both a hole in our lung and there's blood pouring into our lung, and our pressure gradients are just out of control. Unfortunately, with the hemopneumothorax, we can do some stuff at the basic level, but we can't do too much, and we'll talk about that more when we get into trauma. Other causes that will kind of affect gas exchange or respiration for us. If we don't have any blood, all right, blood outside of the body is bad. Blood that is not in our circulatory system is bad, okay? We are not able to recruit the hemoglobin on those red blood cells that are not in our circulatory system in order to carry oxygen in the first place. So if we're losing blood, we're losing our transportation device for our oxygen molecules, okay? Disease processes such as anemia, okay? Some people are not able to create red blood cells, right? Create new red blood cells or have a low red blood cell count in the first place. This can also be for patients with certain types of cancers as well. Hypovolemic shock is blood loss. Okay, hypovolemic shock is too much blood has left our circulatory system, right? Whether it be on the floor or you're actually bleeding internally. And then vasodilatory shock is the exact same thing, where basically our veins have dilated so big, our arteries have dilated so big that our pipes are too big for the actual fluid that's in there, and we lose our pressure gradient, so we're not able to get that perfusion pressure in order for the oxygen molecule to cross into the cellular membrane. Okay, so we have to be able to recognize what is normal breathing in our patients, okay? Normal respiratory rates or ventilatory rates, however you want to say it, is anywhere between 12 and 20 breaths per minute for our average adult. Okay, we want to see a good regular pattern of inhalation and exhalation. Inhalation for about 2 seconds, exhalation for about 3 seconds. All right, we want to see good bilateral chest rise. Okay, we want to make sure that they're not using too many accessory muscles, such as like your abdomen or your neck muscles, or you're not seeing the retractions of your intercostal muscles. Okay, where you guys can actually see the rib cage of these patients when they're huffing and puffing. All right, and we want a good adequate depth. Again, we want to see that nice, good chest expansion. If we can see that nice big chest expansion, right, we know that they are getting an adequate tidal volume. If we see abnormal breathing, anytime somebody's breathing less than 12 breaths per minute, depending on some other factors as well, which we'll talk about in respiratory emergencies. If they're breathing more than 20 breaths per minute, okay? If they're breathing less than 20 breaths per minute, we might need to help assist them actually with breathing, and that could involve the BVM, which we'll talk about here in a little bit. If they're breathing more than 20 breaths per minute, we might have to actually verbally coach them to slow their breathing down. The best way to do that is get in front of your patient, okay? Get down to whatever level they're at, get in their face, have them look in your eye, and you instruct them how to breathe. You breathe in, you hold it for a little bit, you breathe out. You breathe in, you hold it for a little bit, you breathe out. You actually have to coach them to breathe. If that doesn't work, then there might be other measures that we need to do in order to help our patients out. We'll talk about that more in respiratory emergencies. Any kind of irregular rhythm pattern, okay? If they're not breathing in for 2 seconds, breathing out for 3, let's say they're breathing in for 4 seconds and breathing out for 1, or whatever it is, right? There's just some kind of irregular pattern. We need to address that. We'll talk about that more specifically when we get into trauma. If you guys can't hear any breath sounds when you listen in with your stethoscope, if those breath sounds sound really, really far away, if you guys hear wheezing or any kind of other adventitious lung sounds, if it doesn't sound like there's air moving in and out of those lungs, it sounds like maybe bubbles, right? Like if you guys put a straw in water and you blow into that straw, you could hear that exact same thing. It sounds like bubbles in the lungs. That means we got fluid in the lungs, right? Or any kind of reduced flow of expired air at the nose and mouth. This is hard to see. However, we have an instrument called the end-tidal CO2 monitor, which we use to help us with this, and we'll talk about that later on. You guys will also see at some point in your career somebody with unilateral chest rise, where both sides of the chest are not going up and down. Only one side of the chest, only one lung is working. Okay, that's usually because of some kind of traumatic event. It can happen spontaneously in a certain demographic of people, which we'll talk about when we get to respiratory emergencies. But that really says that we have some kind of injury to the lung. More than likely, we have a hole in one of our lungs, and we gotta try to fix it. Okay, they could have look at their effort of breathing. Right, this kind of goes back with irregular patterns and whatnot. Are they really working hard to breathe? Do they look short of breath? This is kind of common sense, guys, right? Their skin. Again, the skin is the only vital sign that you guys can truly see. It's the only organ that you guys can see. If that patient is pale, cyanotic, cool, moist, or any combination of any one of those, more than likely they're going to need some oxygen, okay? And that skin pulling around the ribs or above the clavicles, different inspiration we call retractions. All right, where the actual musculature in the skin is actually sucking in order to try to increase the partial pressure to help the oxygen exchange at the cellular level. Okay, so what does abnormal breathing kind of look like, right? We're going to talk about Cheyne-Stokes breathing with some disease patterns in respiratory, and specifically also in traumas, especially when we're talking about head trauma. But basically, it's the patient may appear to be breathing after the actual heart has stopped. This is what we call agonal respirations or agonal gasps. It's basically like a fish out of water. This is the brain's kind of last hoorah to try to get everything working, trying to recruit as much oxygen as possible before everything kind of gets shut down. Okay. Cheyne-Stokes respirations is often seen in patients with a stroke, if it's affecting the actual pons or the medulla of the brain, if the stroke's located in that area, or if somebody hit their head a little too hard. Okay, Cheyne-Stokes is basically it's a breathing pattern that is irregularly irregular, if that makes any sense whatsoever. So you guys can kind of see the picture down there, kind of in between a minute. So it's kind of like they take these kind of really kind of short breaths at first, and then kind of increase their depth, and then decrease their depth again, and then stop breathing. And then they do it all over again. So it sounds kind of like this. They breathe in. That is bad. Okay. More than likely, if you guys do see Cheyne-Stokes, and you guys will see Cheyne-Stokes at some point in your career, it is very noticeable. And when you see it, you're going to be like, oh my God, that's Cheyne-Stokes respirations, right? More than likely, your patient is not going to have a good outcome. If you see this, you can survive Cheyne-Stokes, but your quality of life is going to be extremely diminished. We also have respiratory patterns that are called ataxic. These are irregular or unidentifiable patterns, such as like a Cheyne-Stokes. These are usually followed in some pretty severe head injuries. If we see ataxic respirations, more than likely our patient is not going to make it. And then we have Kussmaul respirations, which is actually a deep, rapid respiration. It's almost like sighing over and over and over and over again. We see this in patients that have certain metabolic acidosis, specifically patients that suffer from hyperglycemia, or are diabetics that have too high of sugar content in their blood. And we'll talk about that more when we get to the endocrine system. So again, even though your patient might be breathing in and out accordingly, anywhere between 12 to 20 breaths per minute, they have good, adequate chest rise. You're not hearing any adventitious lung sounds, such as like a wheezing or any kind of bubbling, which we call rhonchi, or any kind of rales, which is like if you guys have ever poured milk on top of Rice Krispie treats, and you guys can hear that snap, crackle, pop. You guys can hear that in the lungs as well. We call those rales. We'll talk about those more in the actual respiratory emergencies for lung sounds. But really, anytime that we have some kind of altered mentation or altered level of consciousness, and our skin color is poor, more than likely we are not getting adequate gas exchange at the alveoli level. And this is two of the big symptoms that you guys are going to see for poor oxygenation. So somebody could be combative, they could be irritable, they could be easily pissed off with pale, cool, clammy skin, or just pale skin, or just clammy skin. There's all kinds of different stuff. But most of the time, you guys do have some equipment. Also, your end-tidal CO2, which we'll talk about here in a little bit, and your pulse oximetry, which is a little vital sign machine that we use to see how people are oxygenating. Using all of that, and try to use as many tools in your tool bag that you have to see if actually somebody's actually respirating correctly. Remember, if we do not have that good adequate gas exchange, and we see somebody with that ultramentation, whether they are irritable, combative, or completely unresponsive, and then we look at their skin and they're pale, or they're moist, or diaphoretic, which means they're really, really sweaty, more than likely we have to assume we have to assume that that patient is not respirating correctly and starting to enter the early stages of shock.